for the future. And I'd like to now, do we have Kevin Caserta? Dr. Caserta here?
I am here, Bob. Thank you.
Very good. So Kevin's been serving as our Chief Medical Officer since 2003 at Providence St. Pete's. And I'd like to welcome him, and perhaps you'll give us a few remarks now.
Yeah, thank you so much, Bob. And I just really want to acknowledge and thank our Thurston-Mason County medical leadership and really just applaud you in addressing the issue of physician wellness, physician suicide, depression, as well as burnout. You know, we've realized for years the stresses associated with being a physician or a provider in general, and just kind of watch those burnout rates in many specialties exceed 55%, as well as increased suicidal thoughts among physicians, where we are more likely as professionals to commit suicide than the general population. And then you throw on this, obviously, the challenges associated with COVID-19, the personal risk that many of you have placed upon yourself, all the stresses associated with your families, political turmoil like I can not remember it in my 47 years on this earth. And we can see the impact that it leads on our providers. So in fact, St. Peter, Centralia, and the Providence Medical Group actually participated in the AMA survey, Physician Provider Wellness Survey, earlier or late 2020. And the sad thing and the disturbing thing is 71% of the 368 providers who fill out that survey had actually experienced symptoms of depression or anxiety associated with COVID-19. 2 weeks leading up to that survey, 47%, almost half of those responding felt some symptoms of depression. 55% were experiencing some level of burnout. And the most frankly disturbing point that we had on the survey was that 16 of us had actually thought of suicide in the last 12 months. That was 4% of the providers filling out that survey, 16 of us who had thought of hurting themselves. And I even know for myself, like all of us, the long hours that we've had, the loss of distractions, things that we would generally do to get away from some of the stresses of our profession. I know I was even feeling down kind of that late summer, early fall period. So I actually took one of those PHQ-9 tests that you can get on the internet. And I actually tested positive for some depression at that point as well. And so us having these conversations, I believe us being open as professionals, encouraging and supportive of each other, we just need to do this more and more and more. We are blessed to serve as physicians, as providers in our community, and we need to feel supported. And so I know we got a lot of stuff coming in Providence over the next few months to support our physicians, and thank you for partnering with us on this journey as we all do it together. So thank you.
Thank you, Kevin. That's really heartfelt, and really appreciate your comments. Now, do we have the administrator from Mason General?
Yes, I'm here if you can hear me.
Oh, great. Yeah, Eric Mall. Welcome, and you've been, I know, at Mason General for a number of years now, and we really appreciate you being on board and being, your Mason County is certainly an equal partner with us. So welcome, and we would love to hear your remarks.
Yeah, thank you. And I'm zooming in from Sun Lodge in Winthrop. So apologize for my pretty casual attire here. I do want to, say some remarks and really honor Dr. John Hodala. He's someone I carry still in my heart. Probably the hardest email I've ever had to write was the email, sharing to staff and our medical staff as well that he had committed suicide, and publicly naming suicide, not hiding it was very difficult. And it was partly, I think what I've learned in reflecting on, what was that the right decision was, it helped shift it from being something that, is shame or can, there can be feelings of shame around it. And really, I think turned it more into a tragedy. And I think a tragedy is something you can learn from. And I'll just say from on a personal level, John has given me a gift, in terms of learning. And as we worked with Dr. Wible, as we were grieving as an organization, because of John's death, one thing I personally learned was, something she had shared about how we, especially in healthcare, wear masks, and so I reflected a lot on that, that idea of wearing masks and kind of that automatic response when someone asked me, well, Eric, how are you doing? And I think my automatic knee-jerk reaction, well, I'm fine. And then, I think, life throws us curveballs. And I think it was less than 2 weeks later, I wrote probably the second hardest email of my life, which was, sharing with my board that my wife, had just been diagnosed with stage 4 cancer. And, obviously that wouldn't be something that I'd put in an email, but I couldn't even say the words at that time without, tearing up. And so I came back to that idea of, wearing masks and reflected on it more, and really thought about, well, how am I feeling really? And remove that mask. And I think that helped me, some of the feelings I was having, where, hey, maybe I needed to take a pause. Maybe I actually needed to cry. Or maybe I needed a healthy intervention, like, exercise, get outside, fresh air, whatever, fill in the blanks for a healthy intervention. And I think the other thing I've learned, and again, gift from John, is, historically my focus, has always been on the horizon, and kind of thinking of the future, and, really trying to look at conscientiously working towards, every day shifting, my focus to the present. And so, I really try to view each day as a gift and as an opportunity, and for all of that, I just want to thank John and just really appreciate him. So, and really glad we're having this night tonight. Thank you.
Thank you very much, Eric. Again, heartfelt comments. Very, very nice to hear them. Thank you. Now, before I introduce our keynote speaker, I have someone else who I would love to introduce, and that is your First Lady and my wife, Dr. Nancy Mackin. If I can find her here in all the, let's see where Nancy is. Nance, there you are. Hello. Nope, she's offline. Well, anyway, my wife is an architect, and she is very interested in the housing side of our year that will be that I'll be president, and certainly in housing the homeless. So anyway, I will probably later on, when she is back, I'll introduce her. Now, I'd like to introduce Dr. Wible. And it's very nice that you're going to speak to us tonight. And certainly you've had a great deal of experience in this area. And I can't get over that you run a free suicide helpline, which I'm sure has helped a number of physicians over the years. And I'll be most interested in reading your book regarding the letters and answering them. So, but with no further ado, I'd love to introduce Dr. Pamela Wible, our keynote speaker.
All right, can you hear me?
Yes.
Okay, awesome. All right, well, I just want to thank you all for having this program tonight, and a special thank you to the sponsors of tonight's event, which is Providence and Mason General Hospital. I consider Mason General Hospital on the leading edge of being a progressive organization that's really taken on physician suicide postvention very seriously, and I'm very, very impressed with how they've handled the aftermath of this tragedy. I want to thank Dr. Amy Maurer, who is the Chief Wellness Officer of Mason General, and also Kevin Roscoe, who we will hear from later. They have been instrumental in helping their staff and community heal in the aftermath of the suicide of Dr. John Hautala. So what I'm going to do, let's see, man, let me move this out of the way. I'm gonna screen share now, and I'll just need an indication that it was successful. Hold on. Let's see if I can move this over. So is everyone able to see this? Just somebody give me an indication that
Yes,
it's
it's
okay.
good
looks
to go.
good. Looks good.
Awesome. All right, so what I'm going to do is go through, here's how the evening is going to go. I'm going to share for approximately an hour. And during this hour, I'm going to invite family members and friends of Matthew Seaman. It will be his wife, Dr. Linda Seaman, is with us. And Kevin Roscoe is going to share on behalf of John Hautala. His wife is here, and we want to make sure that Sally feels very welcome here. She's not ready to speak publicly, but we have wonderful people who will speak on her behalf, and we were going to, during the Q&A, which will follow my keynote, we're going to have people share who personally are familiar with these two individuals, share stories and memories. And this is a time when we can grieve together, come together as a community and heal, and also learn strategies to prevent future suicides in Washington State and around the country. And I just want to give a shout out to Olympia. I love Olympia. For those of you who don't know, I worked in Olympia for 2 years at Olympia Family Medicine on Lilly Road, right across from St. Peter's Hospital. And so I have a great deal of love for Olympia. So this event, while it is dedicated to these two emergency physicians in memory of Dr. Matthew Seaman and Dr. John Hautala, I want to also welcome the family members of others on this call tonight who have lost their physician and medical student loved ones in the state of Washington and around the country, so that you please know that you are included in this and are welcome to share it at whatever level that you like in the chat. If you have questions as I'm going through this material, please do place them in the chat, and we have somebody collecting them and organizing them, and we will have quite a lot of time after my talk to answer these questions. And then just to let people know, there is an after event. So this is being recorded. And if you have a question in the chat, your name will not be spoken out loud. The questions will be recited anonymously, and I'll be able to answer them. So please do share from your heart and be vulnerable. If you would like to share personally afterwards in a non-recorded fashion, again, there's going to be a Zoom link at 9 p.m. Pacific time that you can join and be in a private room with me in a non-recorded confidential session for those of you who feel triggered or want to just continue the conversation after the formal presentation. So to move on here, I'm going to, let's see if I can, oh, here we go. So I want to just share how to recover after the loss of our healers. And I want to make this clear that this talk, though much of my research has to do with medical student and physician suicide, this equally applies to physician assistant, to nurse practitioners, to EMTs, anyone who's a health professional. Please feel included in this presentation. So now, when a doctor dies, there are 3 things I'd like to share that happens. We have thousands of patients that will feel abandoned. The average family practice physician has 2,300 patients in their panel. So you have to think about this as really a public health issue. When you have this many physicians dying, we leave a lot of patients doctorless. And it is a huge loss to the entire community. So the way to respond to these physician and health professional suicides is to allow a communal grieving experience, which should not just be one point in time. We should allow multiple touch points of people to come together and heal in the aftermath of these events. So let's see, this is a picture of what it looks like to have a communal grieving post-vention opportunity to heal in the aftermath of medical student and physician suicide. This is a photograph taken in New York City, in which I was instrumental in bringing 500 physicians together. This had to do with the opening of a newly released film called Do No Harm by an Emmy-winning filmmaker that exposes the physician suicide crisis. If you've not seen that film, it is on Amazon right now, on Amazon Prime, donoharmfilm.com. If somebody wants to put that in the chat, you can access it there. So this is in the location of a suicide where a physician stepped off a 33-story building and died in this very location where this picture was taken. And what I did is I brought all these photographs of other doctors and medical students from around the country. And not only did we grieve the death of this physician, but we grieved the death of all of our colleagues who have been lost to suicide. And so this is another picture, because I do think a picture is worth 1,000 words here. This is a picture of what it looks like for health professionals to come together, to love each other, to support each other, to grieve in the aftermath of a suicide. We certainly should not be ignoring these deaths or sweeping them under the carpet, because if you think about it, these people have given their entire lives to helping and healing others, and certainly they deserve some honoring in the aftermath of their suicide. So this is what it looks like. Of course, virtually, we can't, we're not really able to do this now. So tonight, this is sort of a virtual opportunity to do just this. And I just really love this photo here. So I'm just sharing that because we need each other. We really do. These are some of the photos of people that we are honoring. This was, I think it was September 2018. And that's another photo. And I just want to share a little bit about, you'll see this gentleman on the lower right there. His name's Jonathan Drummond Webb, a very famous surgeon. He actually has a Wikipedia page, and he was recruited from South Africa, I believe, to come to run the Little Rock, Arkansas Children's Hospital. Amazing cardiac surgeon with a very low mortality rate, doing surgeries on those little preemies, and incredible guy. He died by suicide. I want to just share that I reached out to his wife several years ago because we did honor him in the film. In this film, there is a scroll, so almost like a Vietnam memorial type scroll of names of physicians and specialty, who have died by suicide. I got the permission from all these over 100 families to honor their loved ones. So I was on the phone with Jonathan's wife. Her name is Lorraine Blanchard. She's also a physician. And so these are very interesting to cold call from obituaries and ask family members if I can honor, or we can honor their loved ones in this film. And I just want to tell you what she said to me. When I called her up, of course, it's a shock, whatever it was, 8 or 10 years after his death, to suddenly get a call out of the blue from the doctor you don't know. And I simply stated that I wanted to honor her husband at the end of this film. And you know what her response was? You're the first person that's called to want to honor my husband in like however long it was, 8, 10 years. And then she went on to say that had he died from cancer or some other cause of death, right, she believes that they would have erected a statue in the middle of town to honor him. And because it was suicide, not only was he shunned, but she, as his physician wife, had been shunned. And she actually almost lost her medical license because the medical board came after her for being on antidepressants, which you would expect after suddenly losing the love of your life. So I just want to point out the differences in how we deal with death when it's suicide versus non-suicide. And I believe that we should equally respect all of these people, no matter what the cause of their death. And so to continue, I want to share that this is tonight a doctor suicide postvention opportunity. I want to also include other health professionals in this. Please don't feel left out. But because I'm mostly involved in doing these eulogies and funeral type things and coming and helping people in the aftermath, I want you to understand what this actually is. And so I will just read, this is an intervention conducted after a doctor's suicide, largely taking the form of support for bereaved colleagues and staff at a hospital or clinic. Lost survivors, that means all of us here, okay? I'm pretty certain all of us on this session tonight have either known one of these two doctors that we are dedicating tonight to, or others in medical school or other physicians that you've lost throughout your career, and maybe you've been passively suicidal yourself. But this is an opportunity for loss survivors, which is us. We've survived the loss of a colleague. We may be at increased risk of suicide ourselves. And so a proper postvention plan allows us as staff to heal from the loss of a peer. And Edwin Schneidman, who is the father of modern suicidology, famously declared that suicide postvention is actually a direct form of prevention of future suicides, which is why it is so important to come together and to do this. There are 5 stages of grief. I think many of you are familiar with this. I want to apply these to health professional suicides in the next several slides, but just to review: denial, anger, bargaining, depression, and acceptance. Originally, these were created by Kubler-Ross to apply to the stages of accepting the death, your own death even, or the death of a loved one. But I do believe people need some sort of structure in this unknown territory. And so what happened is people have started to apply this to a number of different scenarios that were not really the original intention of Kubler-Ross. But I think she would be honored to know that we're applying this to a number of different processes involving grief in our lives. So let's just go through denial first. So denial is a defense mechanism that allows us a temporary way to deal with an overwhelming emotion by sort of avoiding the truth. These are things that you might experience in the immediate aftermath or even years later. For some people, it takes a while to, these experiences, the 5 stages, they don't go in order, so just recognize that you can feel numb all of a sudden. Maybe you're at work and you see a chart note that's signed by one of these individuals, or you see a patient, or you never know when you're going to be triggered to get into this feeling of like, I can't believe he's gone. Maybe write in the chat if you feel like when you heard about these suicides, you had the reaction like, how could Dr. Seaman be dead? Like how could Dr. Hautala no longer be here? It's just hard to imagine. So you have this numbness, this disbelief and shock. And then some people, they might skip denial and go straight to anger. And anger is when the reality sets in and you start to feel really annoyed, and you'll direct it at a number of people, including God. Okay. You can be angry, at God. You can be angry. These are just some examples here. You could be angry at the medical board because the medical board has behaved in ways that really injure physicians' mental health. You could be angry at the very person who died by suicide. That happens. You could actually be angry at patients because you have to continue to see patients, though you've not been able to heal from just hearing that your colleague died. So I want to normalize this so that you don't feel bad for having these experiences. These feelings are very important to feel. if you suppress your feelings, you will be angry and in denial longer. This whole grieving process will last longer. So I want to encourage people with support to fully feel these feelings. Bargaining is very popular in the aftermath of a suicide or any death. This is deal making with usually a higher power for a desired outcome, like bring him back. This can't be real, and you might start to have these stem sentences pass through your mind. What if I would have done this? If only I would have done that. You feel helpless. You obsessively review the events preceding to death, the last conversation, times that you spent together. By the way, if any of this is sounding familiar for anyone, please post in the chat examples of things that you might have felt related to any physician or medical student, health professional loss. This is where guilt comes in. A lot of people tell me they feel guilty. What did they miss? How could I have done something different? They start to just blame themselves, which is really quite counterproductive, but just it's something that we do as human beings. So if you're feeling any of this, please know that this is normal. There's nothing wrong with you. And by the way, one of the places, if you're ever wondering what bargaining is like, I happened to be in Sacred Heart Hospital in Eugene, Oregon, seeing a patient late one night, and I went and sat in the chapel, and I noticed they had a book there in the hospital chapel, and I actually read the whole thing. And it was full of patients, family members bargaining with God to save their loved ones. It's a very interesting thing to read, to just read a book of bargaining. But these are very desperate people who want to save their wives, their grandparents, their newborn babies in the NICU. And so if you're ever wondering, gosh, what is bargaining? Really, if you're near a hospital chapel, that's what it is. That's what's going on in a hospital chapel. Depression is part of the whole grieving process. For some people, this happens right away. This is kind of my go-to strategy myself. I go right into depression. It's not necessarily a major depressive episode, but it's this feeling of, I love the deep rest comment there. My orthopedic surgeon sister-in-law, when I told her I was depressed, she's like, "Oh, you're depressed? You just need a deep rest." I was like, "Oh, that's a good way to look at it. You just need to sleep more." It's true. That's what I generally do. You have decreased appetite. You might find yourself crying. You feel isolated, very tired. And so this is normal. Please know that this is normal. And again, it's important to stay connected to community, because if you're not connected to community, you could spiral into a more serious state of depression and isolation that could then possibly impact your life in some adverse way. And we don't want to lose any of our lost survivors. Then there comes acceptance, which is this gradual willingness to tolerate the loss by no longer resisting the reality, right? You start to feel like, hey, I'm actually going to be able to survive this. It's painful. This is the worst news I've ever received in my life. But, over time, you see that you're going to be okay. Now, what I really want to share that I think is so important for us as a medical community is there is a 6th stage of grief that was created by a man, David Kessler, who worked with Kubler-Ross after he sadly lost his own young son to an overdose. And there's the meaning, which is how not only can we just accept this, but how can we move forward in a way that really honors the person who died? So the meaning is not in the death. The meaning is in us, the still living people who still have these connections with this beautiful person who's now gone from our lives. What do we do with this meaning? So you think about, wow, how does Dr. Hautala live on in me? What can I do to really represent him, to prevent anyone else from going down this path? Or what does Dr. Seaman mean to me? I know many of you who worked with these people in emergency departments around Washington State. And so just as you reach the stage of wanting to understand where to go with this, you might ask yourself, what does this mean to you? And how can you live your life moving forward in a way that not only avoids the self-blame and the guilt, but embraces these beautiful people in a way to honor them and to prevent future suicides. So the stages of grief process, very important to know that the reason why this is important is language allows us to name, claim, and feel our feelings without some sort of structure. This is completely uncharted territory, which can be nerve-wracking for people going through this. I think having a name, kind of like when somebody gives you a diagnosis, even though it's terrible, at least you have a name for what's going on, and you have a little bit of relief that there's the fibromyalgia. Okay, they named it. It's not in my head. Like, this is actually, or arthritis or whatever it is. Like, the name gives you a little bit of comfort because you can start to make a plan, right? So it's important to name, claim, and feel our feelings. So the stages are really scaffolding that allow us to kind of like prop ourselves up in a very difficult time. They are non-linear. I know people want the ABC 1, 2, 3 quick method out of grief. It sort of doesn't work like that. You might go from, denial to bargaining, back to anger. You might 2 years from now go back to anger when something happens. Like, these things come and go. Just accept them as a natural process and understand that your way of grieving is as highly personal and as unique as your fingerprint. Okay, so there's no right or wrong way to do this. And it's a universal experience. Like, grief is part of the universal language of being a human being on this planet. I want to share how health professionals grieve differently than the general public. We really get into self-blame. Yeah, I think, we start reflecting, hey, my job is to prevent death. I failed. Here I am working in emergency department side by side with this guy, my partner. I have great respect for him. We've saved all these patients together, and I couldn't save him. This terrible feeling of self-blame. Not a great strategy, but I want to say it out loud because it's what we do. Confusion. I think as health professionals, we struggle more because we're supposed to know why. We're supposed to diagnose that. We should have known. We should have picked up the signs. Okay. And then we're very super tentorial. Unlike sort of the general public, we're trained to be very hyper intellectual and not emotional. In fact, we're not supposed to be like really emotionally, we're supposed to be professionally distant, right? So we get in our heads and we get in these loops of self-blame and confusion. I should have known. And it's really counterproductive and really exhausting. So I would recommend that you give yourself a break, practice some self-compassion. And this is really interesting. I wanted to share how genders grieve differently because I've been running the suicide helpline now since 2012. I've spent thousands of hours talking to suicidal physicians and nurse practitioners and medical students and others, and also with families in the aftermath of losing their loved ones. And I definitely notice a big difference between how men and women handle grief. And I just want to state this just to sort of normalize your experience. Okay. So men tend to be more physical. Women tend to be more emotional, right? More into the crying, and men want to go out and do something physical to work off the tension. Okay. An example, I just want to give you an example. I think it will really help is when Caitlin Elkins, a medical student, a third-year medical student, died by suicide. Her mother went to her apartment and gathered all her things and kind of like turned their house into a memorial for her daughter. I mean, she was like smelling her clothes every day. She was really just completely saturated in this, like trying to get back into the feeling of remembering her daughter. Whereas her husband, I think, just absolutely could not handle this. He wanted to go on his motorcycle and go on a bunch of motorcycle rides and go camping, and just be out in nature. So I just want to share, it's fine. You decide what you need. His way of grieving is not wrong. Her way of grieving is not wrong, but we are going to grieve very differently, even within a family. Okay, so just, I guess, try not to be judgmental, right? Let's see. Internalizing. Men often sort of internalize their feelings, I think, because we are men in Western cultures and in medicine, are really trained to be sort of the fix-it guys. They're not supposed to cry, not supposed to emote. Women, I think it's a function of estrogen. We call our friends, we cry on the phone. We're a little bit more demonstrative, and it's socially acceptable for a woman to start crying. Okay. I'm just pointing this out. And let's see, individual versus relational. So sometimes men tend to try to do this all on their own. Women, again, I think this is one of the reasons that women have a much lower completion rate of suicide than men, because when they're suicidal, they end up calling their friends or their mother or me, and they reach out for help much more easily, I think, than some men. Now, I want to definitely share something that my husband mentioned. He just happened to pass through when I was putting the slide together. Very funny. And he wanted to make sure I let you know that what he told me is, I don't think you have the male psyche figured out. So just FYI, I just want to say I'm no expert in men. I'm doing the best I can with what I've witnessed. But what's kind of funny about this, gosh, did I spell psyche? I need to add an E to that. So yes, I'm noticing things as a woman. But what I'm going to do for him, my husband is on his birthday here coming up in March. I'm going to get him this book. This is really funny. I would love to know in the chat if anyone has ever read this book. Very important. This is Everything Men Know About Women. This fully reveals the shocking truth that all men need to know about women. Okay. Worldwide bestseller. This is very funny. Let me tell you about this book. If anyone's read this book, please put it in the chat, but you can get it on Amazon. When you open the book, which is, I don't know, 200 and some pages, it's all empty. Isn't that funny? All the pages are empty. There's nothing in there. I think that's hilarious. So it's a great gift. It's a great gift for people in your life. Just a little bit of humor here. But it is true that genders do grieve differently as a function of just our hormones, right? Testosterone, estrogen has an impact on us. And I want to share that sometimes, especially as physicians, we can be judgmental. We can have feelings on feelings, right? So notice if, when you're looking around after in a grieving period, notice if you're starting to feel like, well, I'm grieving the proper way and this one's doing it wrong, or maybe I'm doing it wrong and I'm supposed to be doing it this other way. Good versus bad, right versus wrong, strong versus weak. I would like to encourage you not to sort of embrace this judgmental attitude. Just accept that you can have feelings on feelings. It's normal, but just try to feel your own feelings and have a little less judgment on what everyone else is doing. And so some of the feelings that you might feel, I actually just wrote them out. And in case any of these sound familiar to you, you might want to cut and paste items out of the chat I don't know if people are commenting much on there, but if you notice any of these, beware of feeling like, oh, I'm angry, but I shouldn't be angry. Or I'm terrified I'll lose someone else, but I need to be strong. I'm scared I could be next, but I shouldn't be scared. And I can't feel joy or smile because I'm supposed to be sad. So these are feelings on feelings. And I would encourage you not to do this. I would encourage you, if you're angry, to just feel the anger and not suppress it with the second portion of that sentence. If you're terrified, that somebody else could die, feel that with support. I mean, it's sometimes hard to feel terrified in isolation, but ask for support and feel terrified, scared, feeling joy or smiling. I mean, this is what happens. Like, people will get judgmental and they won't understand why you're smiling or how you can feel joy while you share a memory of maybe Dr. Seaman or Hautala. That is not disrespectful. You are sharing a moment of joy that you had with them, and it's okay to smile and go back and feel that joy. You don't have to be sad, okay? So very important to recognize this. Now, The reason why I'm spending so much time here on the feelings is that feelings offer us freedom from grief. There are 3 quotes that I just absolutely love. These are not original with me. I've heard them and I don't know who I heard them from, but we can't heal what we don't feel. Very important to feel. Feeling is the route to healing. I love this one. This comes from Cassie Daggett, who she really helped me when I was struggling in medicine 15 years ago when I was thinking of giving up my career and becoming a waitress, if you can believe that. She told me any feeling fully felt changes. So this is about moving through the feelings, sometimes with support because they're scary, but I want to encourage you to fully feel the feelings, dance with your pain, embrace your sadness. Don't try to suppress it. There's a feeling of freedom when you can move through this. And when you try to escape grief, you'll just be in grief longer. I hope this is helpful for people. I want to go into specifically, sometimes it's helpful to know what not to do. I can give advice on what I think people should do or the stages that you might go through, but sometimes if we know what not to do, it can guide us in the direction that we should go. So here are some things not to say. Get over it. Move on. They'll say this after a year. It looks like your son's been dead a year, move on. Mothers have told me this. They can't really move on. Don't cry, not good. Be strong. Okay, these are things that you don't want to say. Here's an example, a quote from a physician. We've had 3 physician suicides in my 13 years. I've been at my job since leaving fellowship, and I was shocked at how quickly they were given a cursory, sad nod, then forgotten. During medical school, one classmate blew his brains out, and it received barely a mention at the time from our professors. So the way we respond in the aftermath of these deaths is so important for lost survivors to feel safe and to feel like, they can share their sadness and grief and pain and maybe their suicidal thoughts. When we don't address this or we drive this conversation underground, you end up feeling like your only choice is to go underground yourself. You know what I mean? Like there's nowhere to go. There's a feeling of being very isolated if this is the response. And within medicine, I have to say, I hold the medical profession to a higher standard than the general public. And we should be setting, the gold standard on how to respond to these deaths. And so I want to encourage people to continue to talk, continue to grieve as a community. Another example, my colleague took his own life over a year ago. I was basically okay until then, but it's how everyone reacted that really got to me. The show must go on. We diverted patients the first night, probably because the ER had to see Joe when he came in, which is another, by the way, very unique scenario. Is not only are our colleagues dying, we're in the emergency department trying to save them after they slit their wrists or overdose, so we can feel like this double amount of guilt. Not only did we not recognize the signs that led to this, we actually couldn't save our partner when they were wheeled into the emergency department, right? So continue reading here. The next day, all of us were back at work in the operating room. There was no time to grieve. And we in the department were so stunned, we did not know what we needed and what to ask for. It felt like abuse not to honor him or his colleagues with some rescheduling of operations. I will never be the same. I no longer see medicine as a force for good. It seems like it's a way for other people to make money off of our talent, intelligence, education, or determination. He was my friend. This is just, it just sort of gets me to read this. It's sad. This is not the way that we should behave as medical professionals. I think we can rise above this behavior, that the shame and the denial and the stigma that is perpetrated within medicine. And if you think about this, how can we help our patients who are suicidal if we can't even help each other or ourselves? So we've got to rise above this. So a few more things. I want to share the way to express ourselves around suicide, because this is such a high frictional sort of conversation. There's so much stigma around this. The language that we use is so very important. It's hard to stop, I know, but it's not great to say committed suicide, because committed makes it sound like a crime, like burglary, rape, like it sounds terrible. This is an action by somebody that didn't see any answer for their problems. They died in isolation. It's not a crime. Okay. What would be better to say is died by or died of suicide, just like died by or of cancer or car accident or pulmonary embolus. Normalize the conversation and take the emotional charge out of it by just a simple shift in language. It's still hard. Sometimes I fall back into committed suicide, I might say that, but over 8 years, I think I'm getting better at this. But I'd like to encourage people to use the proper language to destigmatize this. I learned this from a psychiatrist who lost her resident physician's son, Greg Madej, to suicide. Early on, she helped me understand that to use the right language is going to help promote this conversation. Also, it's not a great idea to say successful suicide. It's much better to say completed suicide, because a dead doctor is not a success. How is that a success? That's terrible. Okay. So a doctor or anyone that's died by suicide, they completed their suicide, not successful. Failed suicide, okay? Attempting suicide and surviving is not a failure. That's actually successful. You were successful at surviving a very traumatic instance. So I think just call it attempted suicide. Don't call it failed suicide. So these are just very simple ways to frame our conversation, to take the anger, the friction, the emotional charge out of it. And so what we need most, the number one thing that allows us to heal, is having the support of other people, having events like this, having hospitals and clinics embrace their staff and nurture them and offer them multiple touch points of support in the aftermath of a suicide, which we claim by name and don't hide. We need, I sort of made this easy, community, communication, and connection. These are the three things that we need the most. And if you think of those images that I shared before at the very beginning of the slideshow, that's what I'm saying. That's what we need: holding hands, coming together, putting flowers where the person died, allowing community members to heal. This is, again, at that scene. These are two physicians embracing in the aftermath of a suicide. This, sadly, is a wall in my home business office covered with the pictures of doctors and medical students who've died by suicide. I now have 1,571 doctors and medical students on a registry by name, date of death, specialty, backstory, age, gender, which is why I understand this so well. I've been studying this for 8 years now. And I want to point something out here, the arrow there, that is Dilshad Juman. She is the new attending who 3 days into her job at Mount Sinai Hospital in New York City stepped off the roof of a 33-story building. And here's the picture that I was sent. You see that lower right-hand corner? Now, they threw a tarp over her body. I know this is hard to see, but it's very important. So this is it. This is a doctor who's died by suicide, just covered in a brown tarp. I couldn't get over the way that picture looked when somebody who lived in that building sent me this and was pleading with me to tell her what to do, because she couldn't stop seeing. She just said, "You have no idea what it's like to see the lifeless body of a beautiful young doctor outside my window." She was in her white coat when she stepped off the building. And she said this has happened now several times in her building in New York with doctors stepping off the roof. And so what came to me is that, wow, it looks like every other person in the world seems to get, within their profession at least, some sort of recognition that they died by their colleagues. Policemen wave little flags. You'll have a highway named after somebody that died, whether suicide or homicide. Bicyclists, see the bottom one is a picture in Eugene, Oregon. This is David Miner, who died by suicide. I mean, he died, or no, it wasn't suicide. He died. He was hit by a car. But this little memorial, they continue to freshen up these flowers. He's been dead for like 10 years. This thing still exists in downtown Eugene, Oregon. The bottom left, you see a teenager who died by suicide by walking into the ocean. This is years later. They still have this memorial for her. Of course, you know, Robin Williams died by suicide, and they put flowers and candles. And, you know, sometimes I was thinking, well, maybe it's, maybe they do this for people that die by homicide and not suicide. But interesting, before Dilshad died, there was a quarterback. This is actually from University of Washington in Washington State. A quarterback named Tyler, I forget his last name, died 3 days before Dilshad Juman. So that must have been January 15th, 2018. And within hours of his death, they already had his jersey up, candles, flowers. We love you, Tyler. And so I just want to show it's very important for the person who died, I think, and for the lost survivors to have some ritual to demonstrate how we feel and respect the person who died. And I did not see that happening there. And people were begging me to come to New York and help and this and that. So what I managed to do is I encouraged people on Facebook. I listed a local florist. I encouraged my friends to send flowers to the spot. And then I arrived and actually led this woman's eulogy. So this is the 26th, I think, of January. So this is like 7 days after she died. This is the scene. So I'm only sharing this because I believe every single person deserves to be honored by their colleagues for their contributions in healthcare and not just left under a tarp. They deserve flowers, cards. I mean, not only they deserve it, we are not going to be able to grieve as quickly if we do not go through this process together. So I want to share some data because I think, you know, pictures are worth 1,000 words, but data is worth quite a bit as well. And if you can understand the data behind doctor suicide, we can start to make some real strategic decisions that will help us save our colleagues. So this is actually a graph of the first 1,477 physician suicides and medical student suicides on my registry, which these are organically submitted to me and have been coming since 2012. And about 20% of them are medical students and 80% are physicians, about 20% are international, 80% based in the US. But you can see this breakdown of just raw numbers, just the raw numbers of how many are coming in. And the next slide is really more important, but I just want you to look at this. I mean, there are a lot of them. I didn't know the specialty, or they were still in medical school. Specialties unknown. These are just the specialties that are most popular. Like I don't have a neurosurgeon here. I don't have immunologist here, but these are just sort of the top most numbers of active physicians per specialty. Now, when you compare the active numbers in each specialty, you can see that anesthesiologists are like off the charts here, and they are dying by suicide at twice the rate of the next lowest specialty or highest specialty, which is surgeons. And after that is emergency physicians. So Dr. Hautala and Dr. Seaman are in the third highest risk specialty for suicide. Very important to realize this. Sometimes psych is 4, sometimes it's 5. OB-GYN and psych, sort of when I crunch the data, sometimes switch places a little bit. But it is true out of all outpatient, purely outpatient specialties, psychiatry is the highest for suicide. I think that's just because, you know, they hear terrible stories all day long, and they almost have vicarious trauma from what they hear, right? And for anesthesiologists, surgeons, emergency OB-GYN, they're getting unexpected tragedies all day long, maternal deaths and stillborns and, you know, COVID deaths, and you know what I mean? So just sharing that because I think this is very important. So here are some of the things I've learned. Again, I now have 1,571 doctors on this registry. High doctor suicide rates have been reported since 1858. Doctor suicide is a public health crisis because they say, it's probably an underestimate, but they say 400 doctors per year die by suicide in the United States. Now, if you multiply that by a patient panel of 2,000 to 3,000, depending on the specialty, you get about 1 million Americans a year who are losing their doctors to suicide. So this is a public health crisis. And it should be dealt with some leadership within medicine. A lot of times people say, well, just hope, prayers and love to the family, whatever the family wants to do. The family is absolutely like sideswiped by this, and they can't lead a public health crisis response. They're exhausted and crying. They can barely get out of bed. It's overwhelming for a family. So we want to respect the family's wishes and we want to help them, but we need physician leadership and physician suicide. We need hospitals and clinics to step up and respond with a proper postvention, because it's absolutely too much pressure to have a family dictate the response to a suicide. For every woman who dies by suicide in medicine, we lose 4 men. And doctor suicide censorship certainly leads to more doctor suicides, because it leaves their lost survivors feeling like they're being censored and they're not allowed to talk about their feelings, which is exactly what caused the death of their colleague. Like, we've got to open communication here. I mean, just imagine what it would be like in healthcare if we couldn't talk about high blood pressure or diabetes, or we had to whisper about COVID in the corners and we couldn't talk out loud about this. We have to be able to speak out loud about a medical problem in order to solve it. And it is true that methods vary by region, gender, and specialty. Out west, probably in Washington State, you'll have a lot more gunshot deaths. In India, for example, it's hanging from ceiling fans. And injections, just because they don't have gun access there. So, and those of us who are anti-gun, okay, fine, they'll find another way. If somebody really wants to die and they don't have a gun, they will find another way. It might slow them down a little bit, but they'll find a bridge, they'll find something, they'll find a knife. And so really, we've got to get to the bottom of why people even want to do this in the first place. And how can we create a world, or at least a healthcare system, where we're not losing our own healers to their own hands. I mean, it's startling. And doctors do develop occupationally induced PTSD, anxiety, depression, and suicidality. I think there's a lot of vicarious trauma in emergency physicians, which since we're honoring these two today, they are emergency physicians. And I would bet working in an emergency department for decades takes its toll on you. And if you're not going to therapy, what are you doing? Are you going home and sharing this with your wife? There's a reason why your wife's a librarian. She doesn't want to hear about what goes on in an emergency department. That's too much to burden your wife or husband with. You need professional help, a way to handle this ongoing vicarious trauma. I'll never forget my favorite button that I've seen, or it was a bumper sticker. Emotional baggage limited to 2 carry-ons. I think that's just really funny, but doctors are certainly carrying more than 2 carry-ons of emotional baggage, which they've not been able to release because we've been dehumanized to the point where we're not supposed to have emotions. And so what are we supposed to do? Like, you can't just, this is like containing a boil that you need to have sort of an emotional IND process. We've got to drain this out of our system, because it's like an infection. It could kill you. Personal problems are fueled by professional demands. Sometimes in the aftermath of a suicide, people will say, oh, they're going through a divorce or personal problems. Well, why were they having personal problems? Was it because they're working 100 hours a week? They haven't been able to sleep. They're having vicarious trauma that is occupationally induced. So I really, since this is a medical event tonight, I would like us to get sort of the house of medicine in order, so that we can protect our peers and not sort of blame family issues for this. I think if we had the support that we really require as healers in a very challenging environment, even outside of the pandemic, even on your best day in the emergency department, you're still seeing sad things, right? Even if nobody dies, you're still having to tell people that they might have stage 4 cancer. I mean, that is a terrible conversation to have. And not only does it hurt the patient, it hurts the person delivering the news. Doctors, by the way, choose suicide to end their pain, not because they want to die. They absolutely do not want to die. They just don't know how to end their suffering. And many of them have tried a number of things, including psych inpatient units. And they've tried talking to their peers and maybe haven't been able to develop the peer-to-peer support that they need to feel like they have open lines of communication to express themselves. And by the way, suicide is often very impulsive. I interviewed a number of male physicians who've survived their suicides, and they tell me, because I said, well, how long after you decided you were going to kill yourself, did you grab the gun or the knife or this, that? 3 to 5 minutes. 3 to 5 minutes. I mean, we would have to put we would have to be very heroic to save somebody if we're going to intervene in the last 3 to 5 minutes. What I'm suggesting is we intervene maybe 3 to 5 years ahead or multiple years ahead. I think when we look retrospectively back at some of these suicides, we can see hundreds of missed opportunities where we really could have potentially eased the pain of these individuals who felt so isolated. So these are some of the reasons. I took a subset of 55 people out of the 1,500 and analyzed them for why they died. And this is just sort of that last thing that put them over the edge. I believe suicide is multifactorial. It's multiple things over years adding up. But I was just curious, like, what was that one last thing that made them say, screw it, and throw in the towel? So this is how it lines up here. Mental illness stigma is number 1. Marital distress is number 2. But I really don't blame the marital distress for this. This is the marital distress, that little argument that you have with your spouse at the very end. That was just kind of the end of years of struggling and not getting the help that you needed, maybe with your peers, and vicarious trauma and PTSD and other stuff. That's just sort of like the last little thing, right? A lot of times we just don't know. Why don't we know? Because we're not discussing this. So I can't even find out in some of these cases why they died, right? Sometimes it's the medical system. I know many of us feel very frustrated by EMRs and everything else. Sometimes it's a medical error. Sometimes retirement, like we feel like, what's the use? Like, who am I if I'm no longer a doctor or a surgeon? What, and maybe we've let our personal relationships go by the wayside because we've been workaholics. Now that we're not working, we're sitting at home with a stranger called our spouse. And we haven't been able to develop the deep relationship that we want with them. Certainly hospital corruption isn't easy. Being in the wrong career, many people are sort of forced into this by family or cultural reasons, or, then some people lose their job, and, isolation, bullying, illegal activity certainly isn't going to help you feel very good, especially when you're caught for Medicare fraud or something like that. This could put people over the edge. Financial issues and physical illness, as in you have a terminal condition, you don't want to suffer, so you're like, this might be the way out. I'm going to give examples because I think it's very important to read the sentences that family members and friends have told me that were sort of that last little thing that put people over the edge. So there's a bipolar physician who hid his mania as enthusiasm. I can totally relate to that. I think I've done that. Doctors who underestimate the severity of their chronic depression and bipolar and never sought help. Untreated depression, resistant to seeking care he needed. His physician wife reports probably due to license repercussions and other things. Insomnia, abusing drugs to keep himself sharp, and also was lonely. A kind, happy doctor with untreated depression, because some of these doctors have that happy exterior, so then you don't see it coming because they just cracked a joke. They've been smiling all the time, thumbs up to the surgical team, and now they're hanging in a closet. Now, how did that happen? They're hiding their feelings. Bipolar, never treated, domestic violence, drugs, depression, fear of seeking help. As a perfectionist, after a job fell through, he felt like a failure. Insomnia, anxiety, a fear of psych hospitalization. They don't want that on their record. They don't want to have to explain this to the hospital credentialing committee. And it's very intense for people who feel so isolated that they have to hide that they have pain, emotional pain. And so at this point, I would like to take a moment to really honor this beautiful emergency physician who we lost in September, I believe it was, Dr. Hautala. And this is a picture of him and his lovely wife who is with us today on this call, Sally. I just want to send some love her way. She lost her beautiful husband. And this is him at work mentoring this lovely young man named Darren. And I'm going to let Kevin Roscoe share for a little while if he can be unmuted. Kevin knows both of these people in this picture here, and I would love for him to share a little bit on behalf of John and maybe share a few little stories about him. So Kevin, if you're there.
Well, thank you, Pamela. And I have goosebumps all over my arms right now, and I'm just flooded with emotions and thinking. So that is my son Darren when he did a job shadow with John. I chose John out of all the emergency room physicians. I felt closest to John. When I first met John, he used to bring me chocolates in my room every day. He was the one person that could break down all the barriers that were between doctors. He was incredibly affable, always showing me his iPhone and always excited about everything, all his technology and things that were happening. And, I remember when he got his gastric sleeve, he got a gastric sleeve to lose weight, and he kept trying to convince me because I'm super fat, he's like, you should just, I feel so good now that I have my gastric sleeve, and I said, I'm too scared to get anybody touching me surgically, but I still like to eat a lot. And, he was a real genuine person. I mean, I don't know. He came to my lake house with his wife, Sally, a long time ago, just because, he was really the only person at Mason General that I invited to my lake house, because he was such a personable guy and just a lovely person. And I can't express the shock enough, when you were going through the slides of, I'm still in shock, to be honest with you, that this happened. And I would really like to honor him, to prevent this. So it's a great presentation. I think I'm going to, I think I'm breaking down a little bit, but, I think Dean is also on the call. I think if Dean had something else he could mention about John, because if you were on, Dean, I
Sure.
don't know.
Yep, sure.
Take over for me because I can't talk anymore.
Okay. Well, I knew John very well, probably for most of his career. I was the ED medical director when we recruited John. I say we, the group was a very tightly knit group, and we recruited him away from Aberdeen. Hopefully nobody's here on the call from Aberdeen, but we stole him away from Aberdeen. Actually, we stole 2 docs from Aberdeen, but nonetheless, we recruited John, and I knew John for a very, very long time. He was the guy who would give you the shirt off his back. And in fact, there was an episode one time where a patient, I don't remember the exact details, but a patient didn't have access to their car. Something had happened and they didn't have a ride. And so John was working the night shift. So he said, well, here, take mine and I'll just get it back from you tomorrow. And that's just the way he was. So John was a very generous guy. And yes, iPhone fanatic for sure. Anything Apple, John was a fanatic. He called himself a nerd. He was a nerd. So I'm probably the only one in the room, though, too. I don't want to jump ahead at all, but just to put it in context here, I'm probably the only one in the room that knows Matt Seaman as well. And I definitely want to be able to speak to Matt. I think it was within a week when we lost John, my residency program sent out a note just around physician burnout, and they were honoring Matt. And I had no idea that Matt had died, could have been a year before, but it was a considerable shock to me to lose 2 people that I know very, very well in a very, very short period of time, at least in my own mind. And I'll certainly come back and talk about Matt later. But, it's been an enormous shock to our group. And I would argue that the ED group is not the same. They've really changed in some ways. That closeness that we always had, I think, is a lot more tentative at times. It's just different because, we were together for so long, like a family. So
Thank you, Dean. And I'll just add one more thing. The funny thing about this photo that she has here with Darren is John told me his number 1 priority that day was to convince my son not to be a doctor. And his first patient he brought him into was he had him do a rectal exam with him, which totally, my son just went, what is happening? He's now a software programmer, completely is nothing to do with medicine that killed it. So John was very successful in what he set out to do.
Wow, thank you. Thank you so much. At the end of the presentation, we'll spend some time during Q&A just focused on more stories from people who know John and Matt. To continue here, I want to share, this is very interesting, what I found in an 1858 textbook about a manual for psychological medicine. I wrote an article, Why Happy Doctors Die by Suicide, on my blog that was picked up by Medscape in 2018, became one of their top 10 most read, most commented articles that year. And I just want to read this quote. It really hit me. Carlini, a French actor of reputation, consulted a physician to whom he was unknown on account of the attacks of profound melancholy to which he was subject. The doctor, among other things, recommended the diversion of the Italian comedy. For, said he, your distemper must be rooted indeed if the acting of the lively Carlini does not remove it. Alas, ejaculated the miserable patient, I am the very Carlini whom you recommend me to see, and while I am capable of filling Paris with mirth and laughter, I am myself the dejected victim of melancholy and chagrin. And this just, I think of Robin Williams, I think of doctors who are very happy, joking around, even up to the point that they die, making other people laugh. And not attending to their own needs. This is important because there's a lot of sort of happy doctors out there wearing a mask of happiness that is not congruent with how they really feel. I would like to encourage physicians to feel safe, at least tonight, to share authentically in the chat and during the Q&A, because it's impossible to be happy all the time, okay? You can't. Please stop pretending to be happy if you're not happy, okay? It makes it harder for us to help you. If when we ask, how are you? And you say fine, but you're really passively suicidal, it sort of puts up an obstruction. And so why happy doctors die by suicide? I'll just quote here. Physicians are treated as criminals, tracked more closely than level 3 sex offenders, reports a surgeon. Answering all these questions on applications. I know many of you know about these mental health questions that are very invasive and should be illegal on hospital credentialing and medical board applications. The subtle unspoken lesson is you had better be squeaky clean mentally, morally, and physically. If you step off the shining path, bad things will occur. I have known 7 male physicians who died by suicide, most with a happy exterior. Why? They cannot confide in colleagues for fear that their colleagues will turn them into hospitals and boards, because sometimes you need a peer reference. And sometimes on the peer reference, they want to know about the mental health of your colleague, right? So they don't feel like they can trust you, right? And there goes their privileges and livelihood. They can't confide in their spouses because during rough patches mentally, their marriages are already in trouble. If they share psychological problems, they probably fear that the wife may use this as ammunition in a future divorce. So they keep on smiling right up to the hour they die. Okay, I think he's made his point well. I want to share a little bit about marital distress. Again, some of the experiences that kind of were the last sort of culmination of many years of pain for people. Controlling amid a failed marriage, and this was a murder-suicide of a wife. Sadly, about 2% of the people out of the 1,500 were murder-suicides, and that reflects the same statistic in the general public. About 2% of suicides are murder-suicides, and this was a murder-suicide of an anesthesiologist wife. This is very interesting. When I heard about this was a happy guy, a great surgeon under marital distress amid a divorce. And this is another physician who told me I had shared and discussed with him your talk on suicide prevention. Not surprisingly, he was a leader in our physician community in many areas, including physician wellness. So this is startling. You could even be a leader in physician wellness and still die by suicide, which means we have more work to do. A well-loved doc, newly into practice with spousal infidelity, lack of joy in marriage and work. Classic happy doctor, rumored divorcing his high school sweetheart wife, and his wife left him after residency and he wasn't the same. So these are just examples of yes, we're human. If we have infidelity in our relationship, we respond like any human being, and we could get overwhelmed by it. So it's just important to notice. Recently retired and marriage failing. The medical system is another system. I think I don't have to drive this home too much because I know many of you are feeling distressed by just your workload and what's going on, especially amid a pandemic. Rage and frustration with the system, retired but disliked EMRs, hospital system, regretted going to medical school. To look back on your life and regret your career, I mean, that's very overwhelming. Overworked with 36-hour COVID shifts and marital issues. You can see it's hard to even name one thing because there's a blend of things. It's overworked and marital issues, right? A savior complex, overextended self, and felt tortured as unable to fix everyone. This perfectionist idea that we can actually cure all of our patients, right? It's unrealistic. Okay. I want to share a few direct quotes from the daughter of an orthopedic surgeon after his suicide. I think this gives us some insight into things that we don't otherwise see because we don't follow physicians home after work to witness this. But children pick up on quite a bit. So this is orthopedic surgeon. His letter said, "Sorry, I couldn't fix everyone." That was his suicide note. "Sorry, I couldn't fix everyone." He had a people pleaser personality. The medical culture was something he was frustrated with, though. Hip implants he did that were then recalled, hospital drama, politics, managing medicine as a business when it's personal, and life and death issues, it all affected him. Then she said, insurance companies are so stressful. Insurance companies should not be in control. It's stressful getting the approval to do a damn surgery in the first place. If you don't get it, the patient may die. If you save them, you may get sued. Totally messed up. And then even your implants can be recalled. This is an orthopedic surgeon. And she said he was basically dictating alone on a Sunday morning. He bought the rope that morning on his way in, must have planned to finish dictating, but apparently he got so overwhelmed, he stopped and he couldn't even get through dictating because the work ethic that the physicians have. So many of these cases on my registry, they're checking, they're returning phone calls, they're reviewing abnormal lab results, before they're dying by suicide. They're making sure, because they want to finish everything and get a little gold star for being a good doctor before their suicide. It's really very different, I think, than non-medical professionals. Like the average teenager is not trying to finish their homework and turn their algebra in before they die by suicide. The average veteran is not trying to take care of all these things before they die, right? The doctors are actually working up until the hour they decide to die. They just come home from work, The note was short, basically said, "Sorry for all the patients I couldn't help." 2 sentences. And the first line sticks in her mind. She says, what she wants every orthopedic surgeon to know, and I'm just drawing this out because I want every doctor to know this, is the conflicting thoughts, emotions, and level of stress they deal with. Days of absolute chaos is something I understand and dealt with as the child of a physician. She witnessed this. There was a day he stood alone in his closet, could not dress himself. My mom had to go in and dress him and snap him out of it. Calls at every hour of the day and night, being on alert all times, even sitting in church, his beeper would go off. He got in a lot of car accidents, rushing to the hospital, ran out of gas many times because he was so fatigued, almost lost his driver's license due to tickets. And then he lost a lady in the OR on Christmas Eve, had a mental breakdown on Christmas morning in front of 4 kids. I mean, this is unrealistic. We cannot expect physicians to work at this level, or anyone in healthcare. And then, you run into a medical error, you can see, self-doubt after a bad surgical outcome and hospital peer review. These are other examples of specific things that led directly to suicide. A perfectionist who had a patient complication from a medical mistake as a 3rd-year resident with an insensitive attending that then led to self-doubt, stepped off the 8th floor of a teaching hospital while on call. A minor medical mistake and a perfectionist who could not deal with the tarnished reputation. A major at-fault malpractice case he knew he would lose. His reputation was everything. And I just want to share here that I want everyone to realize that if there's a perception of a medical error by a patient, even if it has no merit, it still can torment you to the point of leading to your suicide. And I just want to share the medical board complaints can lead to suicide. And at this juncture, I'd like to honor Matt Seaman, and I'd like to welcome his emergency physician wife, Dr. Linda Seaman, who's with us today, can be unmuted. What a beautiful picture. Look at this gorgeous photo of the sweet man and It's like hard to believe he's gone. So I would like Linda to be able to share on behalf of her love of her life, if she'd like to share anything for 5 minutes or so here. We would love to know more about your husband and the circumstances.
Well, thank you, Pamela. Can you all hear me okay?
Yes.
Okay. Just thank you. I feel a little teary right now because of all the things you've said. It grief takes a long time to master and walk through. So, but I want to share specifically for this discussion tonight the issues that led, I believe, to Matt's suicide. He was a stellar, amazing man. He was brilliant. I think I got IQs that said I was a genius, you know, growing up, but he was way more brilliant than I am. And he was definitely a perfectionist. And the story was he had always said, Linda, I want to work 30 years in the ER, no more. And we were on year 33, and Matt had decided to cut back and change locations to kind of get some, you know, just some, it changes healthy, I think. And we always both felt that work was therapeutic. But it was Christmas 2016, and I get a phone call from Matt. He's coming off a night shift, and this is my husband who has, you know, valedictorian, Phi Beta Kappa. He always was working for excellence. I mean, above standard, I think. And he researched and authored things. And he says, Linda, I think I cannot tolerate this insanity anymore. And Matt was not an emoter. I'm an emoter. I'm a woman, but he was not an emoter, and I knew he was done. So he retired the next month, gave 30 days, and moved, you know, went on to work somewhere or come home. And immediately that same month, he received a patient complaint from the medical board. And he kind of really didn't even care about it because there was no damages. I mean, she was complaining that he was unprofessional, and he thought, oh, this will take care of itself. And he and I both have managed correctional medicine patients here in Yakima because it's a job nobody else wants to do. And we were used to getting complaints, and they usually went away. But he called and he said, well, what is the complaint? Because there was no information in the letter. So they said, well, we can't give you any information right now, but we're getting it. So he drove up to the ER medical records, and they wouldn't give him any information. But because they said only a lawyer was permitted to look at this now because there was some other issue going on with this plaintiff. And he did find out that it was the wrong date. So he writes the board back and said, well, I haven't seen this woman since April of 2015, and we're now 2019. But I do recall, and he wrote down what he recalled because they wanted a response in 30 days. Anyway, I only bring that up, not to go into any details, but that he was always trying to do due diligence. And he kind of just handed it off to, we have a local lawyer who's handled these in the past. And we traveled the whole year. It was a wonderful year. We were in the Galapagos and Peru and all over the world, really. And it was a wonderful early retirement year. So a year later, January 2018, he gets this very stern letter from the medical board saying, well, we've had one peer review, a retired ER physician, and it was scathing. Obviously, this person didn't know anything about Matt or his standards of practice or anything about him at all. He's even written books on pain management, and the guy was questioning whether he should have given this person certain pain medications and blah, blah, blah. And I just said, oh, Matt, he doesn't know what he's talking about. But then within 2 weeks, he got a letter saying that yes, he needed to sign this stipulation, and it was a very scathing stipulation. And Matt said, I'm not going to sign that because this guy, it's based on one reviewer, and you know, I'm not going to sign it. It'll be fodder for a lawsuit if I sign it the way it is. Well, that was the beginning. Let me just say two things. Number one, stigma is very, very real. And number two, litigation threat or stress combined with an attempt to humiliate who you are as a person when you've practiced for 33 years and done amazing work and done all that we do as physicians, litigation stress or the threat of it is real. And I saw a change in Matt. It was just that spring. It was sort of the harassment factor. And the letters kept coming from the board saying, you have to sign this or we're going to have a hearing, and you're calling him a public safety issue. I mean, they humiliated him in these letters. And he kept saying, I just don't want to deal with this. So November of that year, he went to a hearing, and my daughter, who's on this call, drove him over, and he said, I signed it, Linda. I said, why did you sign that? You know, it's going to go right to a lawsuit now. And it did. So he said, I signed it because, number one, Team Health wouldn't guarantee me that we wouldn't have to spend our retirement money to defend it. And it would cost $50,000 or more. And I don't want to spend our retirement money on that. And I'm retired. I don't need my license. And I said, well, I understand your logic. That probably was a good thing, but you know who this person is. And she's a professional litigator as far as I'm concerned. And you know this is going to go to a lawsuit. And he goes, well, I hope not. Well, that next year, talk about marital stress. Just talk about family stress. Talk about stress in general. The lawyer that got involved was malicious. That's all I can say. Malicious. I mean, within months, I was named on the lawsuit. Our whole marital community was named on the lawsuit. And when we would call Team Health, who held the parent company for the malpractice, they said, well, the only reason they do that is because they're trying to exceed your malpractice limits. Well, you're talking to a woman here who's never been sued. I mean, think about this. This is all new. And you're going, what? You're going to take more than why do we pay malpractice if you're going to exceed malpractice limits? Oh, and Matt's lawyer would say, don't worry about it, Linda. They probably won't. I said, well, then take my name and the marital community off of it. I mean, it was just this, everything was a catch-22, everything. So Matt went into the hospital. He became more and more depressed. And I was the bad guy who said, Matt, you need to go on your antidepressants. He had been on them twice before during some stressful job changes and things like that. And he'd done well on them and gotten better. But he had stopped them when he retired. He said, I don't need these because I've retired. I'm like, well, I think you do need them because you're starting to show signs of depression, irritability. And Matt was a very cool, calm, soft-spoken guy. I mean, he loved to talk about certain subjects, but he was an introvert. So this change in behavior was extremely unnerving to me. I could see he was getting depressed. So he went into the hospital for 1 month, or excuse me, 1 week, said, oh, I'm doing better. I can handle this, and went out. And when I had gone on a trip. When I came back, he wasn't any better. In fact, he was worse. So by December, we're now 2 years out from all the retirement and the insults. He had to go back into the inpatient hospital here in our town. And I can only say that it was very substandard care. He never saw a doctor, and I put that in the chat when that came up earlier. Never saw a doctor. The two psychiatrists who were in charge didn't want to see him, never have been told why. And I've asked them, and they just said, well, we had other things, it was so sad. And I thought, well, he had had 2 wonderful psychiatrists who had helped him during the first 2 depressions in the early parts of his career. And they had indeed helped him tremendously. So we didn't have anybody in this town for him to even see. So he finally checked himself out, even though he still had suicidal thoughts. And I said, I don't know what to do, Matt. We need to go over to, Seattle or someplace. And I had made arrangements for him to see another physician and get extra care in Seattle, but our insurance wouldn't cover it, and it was $600 an hour. So Matt didn't want to go because it was too expensive. And I said, well, we have to do something. But the bottom line was he said, I have got to get through. This had now proceeded. The litigation was stressful and had proceeded to a deposition. And he says, I've got to get through this deposition. I'm the only one who can do this. And while he was in the hospital, I think, and I sent you some of Matt's journal quotes, you know, Pamela, all he would say was, this has got to go away. I can't handle this. You know, this is my husband who's Mr. Competent in everything. I can't handle this. We have got to settle. We've got to settle. And all the efforts and I didn't get involved with his lawsuit until he went into the hospital in December. All his efforts to try to settle were just diverted. You know, the bottom line, and I'll skip to the bottom line. The bottom line was his attorney wasn't in his camp. His attorney was getting paid by Team Health's legal team, and his lawyer was not giving him good advice. You have this sense that somebody's just making money off of you, because Matt was literally dying and there was nobody wanting to help him. They could have settled the case. They could have. In fact, let me just say that up till the very end, Matt, 48 hours after the deposition, came home not happy. I said, don't you feel better that this deposition's finally over? And he's like, no, I still want to die. I can't handle the stress. He says, there's just going to be more. I've got this litigation to look forward to. And I said, well, so we called his physician, his psychiatrist. It was an assigned telemedicine psychiatrist. And we called him. I called him twice. I put Matt on the phone once, and I called him even the next day. No call. And on Thursday, the morning, 2 days after the deposition, I found my husband. He'd hung himself on our gym set. I mean, I was devastated. But and let me just share one more thing, and then I'll let you take on the rest of the presentation. But do you know, I became the defendant in the malpractice case. I was told I now was the defendant. Here I am, and the plaintiff's lawyer and Matt's lawyer send me letters within the week of my husband's suicide saying, when do you want to, get together to talk about the lawsuit? And I'm like, I just got irate and I hung up. I said, I'm not ready to talk to you about anything. And it was a month and a half, and I ended up getting a different attorney, and I settled the case. Matt died the end of March, and the case was mediated and settled in July. Now, why didn't Team Health settle it earlier? My husband would still be here. So I feel physicians are greatly abused, misused, and there was no reason for this, especially in a non-meritus case. This woman had no damages, but she was. Anyway, I don't want to talk about the case. So
we'll continue to share more about Matt in the Q&A, but there's one thing that Linda told me recently that is just like infuriating. Do you want to share what you heard 2 or 3 days after he died? Did you have an attorney call you and tell you something just in the literally, it was 48 hours after his death, right?
Well, the plaintiff's attorney called Matt's attorney, who was reaching out to me, and said, I think your husband killed himself because he was so guilty about his poor care, quote unquote, from the plaintiff's attorney. He's a bad guy. I won't say it in this conference, but anybody want to know who he is? Anyway, I'm still processing. I feel better. It'll be 2 years at the end of this March, but I've made huge progress, but it set me back. Grieving, just having to deal with all that stress, finding my own attorney, preserving my Matt's and my hard-earned retirement. I mean, it's been not the way a physician or any physician wants to end their career. And by the way,
Yeah.
Dr. Roscoe, my daughter, we wouldn't let her go into medicine either. In fact, she's a software engineer like your son. So
God bless her.
I just wanted to let you know the great minds think alike. But my daughter's on the call, so she can speak for herself.
So we'll invite others to share about Matt and John in just a little bit. I'm just going to finish a few more slides. Thank you so much, Linda. I know that was extremely difficult, as everyone can witness, like people who were close, these loss survivors close to these individuals, were breaking down just sharing stories. So this is why we're here together. This is part of the grieving process. We need each other, and we need to be able to express ourselves. So to continue here, and I just love that photo. I could feel like I could sit on this all day. So retirement is also a stress, just to kind of go through and culminate with some of these reasons. Depression in retirement, strongly identifying with your professional life and wondering, what you have left when you retire. Just these are all pretty self-explanatory. Hospital corruption, of course. We didn't go into medicine to be accomplices in criminality, but people find themselves in situations that are unethical and without support. Whistleblowers can die by suicide. Just getting stuck in corrupt hospitals without anyone to talk to. As a new doctor without any help. Wrong career. Again, people are sometimes pressured into medicine by, family and such. And so then job loss. Now, people can lose their privileges for mental health issues or can be accused of sexual harassment. The second one, it's just really sad because there was no harm done. I think he had asked a nurse out on a date, and then she got all upset and somehow reported him, and the hospital legal counsel, CYA, basically recommended terminating him, and he went home and shot himself. I mean, after all that, all that education, and there's got to be a better answer, than that. And again, there are people who end up overprescribing pain meds, but, they need help, right? It's sad to throw all these people under the bus. People make mistakes. I was friends with a woman whose father was overprescribed pain meds, ended up in prison. I think he died in prison. Very sad. There's got to be a better way here. Isolation, overwhelmed without family or peer support, residency, getting transferred to new programs, not having the social support. Again, that's another beloved Happy on the outside, successful physician divorced years ago, whose mom was recently diagnosed with stage 4 cancer, and he shot himself. Actually, crazy. He shot himself on September 17th, which is National Physician Suicide Awareness Day. I don't even know if he knew that, but bullying, we know that's a huge problem in medical education. This one really gets to me. A type 1 diabetic, as an orthopedic surgery intern, was told by a resident or his attending, "You'll never make it with diabetes." So he shot himself a few days into residency. I think what I want to drive home here is words really matter. You might say something in passing. Just recognize that you can wound or save somebody just with a sentence. And I'm going to share some simple things at the end that we can do to really save lives. Obviously, illegal activity is going to come back to bite you, and that can destabilize you as well. Financial issues, people who can't afford to retire, debt, the student loan debt right now with medical school is just outrageous. Here's 1 year post head injury. This gentleman killed himself in front of the family. Another one had a CVA, lost dexterity in his arm and couldn't operate. So, just important to recognize these. So in general, when I look through the reasons why doctors die by suicide, it's primarily professional. And I feel like the personal issues are sort of secondary to the occupational wounds that we sustain and don't have support in a obviously very difficult career, especially so during a pandemic. And so here are the solutions, 3 solutions. The first one is more a system-wide solution, and I think we can all, at a hospital level, you can certainly do this. I want to share that we should, the doctors avoid seeking care for fear of checking the yes box. Now, as far as I know, both John and Matt did seek mental health care and were on medications. I don't know, just they're, most physicians have reticence. They get concerned about if this is all going to be discoverable, and like the medical board is going to be reading their chart notes. And so I think it's really important to replace any sort of mental health questions with current impairment questions. A good way to phrase this on a licensing application or a hospital credentialing form, or even, to apply as an in-network with Regents Blue Cross Blue Shield, they're asking these mental health questions. By the way, these list of questions there, this came from an Alaska license in 2019, I believe. I pulled this off the Alaska license. And since I've published this, I've had a number of physicians go head on head with their medical boards. And I know in Alaska, they've had these removed. They've now updated the questions. There are 4 states that ask no mental health questions or competence questions: Michigan, Hawaii, Connecticut, and what's the other one? New York. And you have to ask yourself, well, are physicians just not up to snuff in those states because they didn't ask the question? I mean, why even have this question anyway? Just you have to ask yourself, if some states aren't doing this, why are other states asking 25 yes or no mental health have you ever questions, which is absolutely invasive and should be illegal according to the Americans with Disabilities Act. So do you currently have a condition that impairs your ability to practice medicine safely, would be the way to phrase this. I also, number 2, think all of us in healthcare need confidential, non-punitive healthcare, mental health care. And this should not be discoverable. We should be able to know that HIPAA applies to us. Like, we should be able to say whatever we want to our psychiatrist, our pastor, our counselor, social worker, whoever we see, without fear of having to hold back. And because these questions still exist and people are looking for some way to process their pain, I want to just recommend something that I see that works really well, sort of a interim step if you can't get into a psychiatrist or a therapist. There is this, what I recommend, sort of a DIY therapy, which is journaling. This is a picture of my 8th grade journal when I was 13. I just reread this. It's horrifying. It's depressing. I think I was in denial about some of the things in my childhood that have created habitual behaviors in me as an adult that I'd like to rectify now. I think it's useful to journal because it helps you prioritize your fears and concerns. It's a way of processing your pain without having to pay a copay. If you're in a situation where you can't get into therapy, this is sort of, in my mind, the next best step. And you might want to bring this to your therapy appointment because you'll write some very interesting things in here. It allows you to track your triggers so you can better control them. It provides time to process vicarious trauma. And I recommend all health professionals have a journal by their bedside that they can just write, their anger, their pain, the things that they saw every day. It will help you promote self-discovery and healing. So just a shout out for the value of journaling. And finally, in closing, I think this is the most important thing that we can all enact immediately, starting tonight. Immediately after the session, you could do this. There's a very simple thing that you could do, but I want to share how important it is. Appreciation. Now, this woman, let me just share something here. This woman here, her name's Paige Hunter. She left 240 notes on this bridge, where it's a popular bridge for people to die by suicide in the UK. She was suicidal herself after being raped when she was 14. You can read about her online. This is an amazing woman. She at age 18 went back to the bridge, I believe, and started just leaving these notes everywhere. Well, actually, she was going to die by suicide. And she decided at the last minute, I think what it was is she was on the bridge getting ready to step off, and somebody came to her and said something comforting to her. So I forget the details. And she decided not to die by suicide. And then she went back to the bridge and left these notes. And she left these notes all over this bridge. I mean, it doesn't take much time to write like a few sentences. And I just want to show you some of the things she wrote, because these things that she wrote would also work for doctors. You don't have to be a teenager on a bridge in UK. Like, these are universal sentiments that we could share with each other on a daily basis. I think we need to hear this. Please stop and breathe. There are better options and so many people who love you. I like this next one. Place your hand over your heart. Can you feel it? That is called purpose. You're alive for a reason, so don't ever give up. You don't want to die. You just want the pain to go away. You have the power to say, this is not how my story will end. I know you're tired. I know you're physically and emotionally drained, but you have to keep going. The world is a much better place with you in it. So this works for doctors too. This isn't, again, not just for teenagers. This is an example of 2 quotes, and then I'm going to go into Q&A. I keep every note from my patients. It has definitely prevented my suicide. There are days I want to give up, but I see the letters, thank you cards, even art, knitting, and jewelry from patients, and I keep going. I'm reminded that my life is about more than my pain and suffering. So that's from a female physician. And I can't tell you how many people have revealed to me that their little box of thank you notes from primarily patients has prevented their suicide. You know, little notes, just like that bridge scene, little notes. And then finally, I want to share, this is very profound. This was a text message. A male ENT told me, hi, Pamela, here's the text that prevented my suicide. This came from a resident, by the way, that saved an attending. Hey, I'm sorry. I'm so sorry about your patient. That sucks. I'm very thankful that we have you as an excellent otolaryngologist to learn from. You take care of so many sick patients and do a marvelous job educating us how to do it safely, skillfully, and compassionately well. Thank you for that. It's been a particularly hard year for me, but I'm surviving. Thanks for all you do, Pamela. But this is profound. I mean, it really only probably took I don't know, depending on how fast you type, I'm very slow, but you know, the younger generation can probably type that out, or maybe you read it into the thing and it just, I don't know, like, I mean, this couldn't take more than a minute or 2. I don't think the resident knew that it was that. I still don't know if this resident knows that the resident prevented this ENT surgeon's suicide, but something this simple, which I'd like to encourage you at the end of tonight to text somebody that you appreciate. I mean, it can get there instantly. You don't know what they're feeling. They could be feeling miserable, and your text could turn things around. Okay. I want to just share in closing, I have a free audio book of physician survival stories. The physicians in this book, by and large, are still alive. And these are their processing, sort of the physicians contact me when they're, you know, passively or actively suicidal, and they're actually going through the pros and cons in their mind of why they should maybe die or why they should stay. And this is a book of very authentic letters from people kind of comparing their pros and cons, and most of them survived. And so I think if you ever want to understand the psychology of what goes on in a physician's mind, and there are some PAs in here and others, it's primarily physicians and medical students, I encourage you to download this free audiobook. If you like the sound of my voice, you can hear me for 3 more hours. It's also hard copy on Amazon if you like. So I have one final request before moving to Q&A. So this is me, kind of in the same outfit. This is how I look now. Although I have glasses, can't read small font anymore. I'm getting older. I want to share, this is a picture of me when I was 36. I'm 53 now. Here I am, 36. Now, why am I showing this picture? I was suicidal. For 6 weeks, I could not get out of bed. This is me laying in bed, immobilized. Totally, at the time, I felt occupationally induced because I was just tired of doing this assembly line medicine routine. And so my request here in closing, back to the mask, and I'm not talking about a COVID mask. I'm talking about the mask that covers up our emotions. I think that was what Dr. Gushee was referring to earlier. And we've got to take off this mask. If you don't remove your mask, nobody can see how you feel. And that's how we figure out what's going on. So I would like to encourage people to remove their mask, and at least tonight on our call to share something maybe they've never shared before. The Q&A and the chat's going to be, anonymous questions are going to be submitted, and I'm happy to answer them. I'm sure Kevin and others can answer as well. I'd like to just close out now with the official keynote, and I want to just sit on this slide for maybe 5 or 10 minutes and invite anyone else in the audience who has a personal relationship with Matt or John to share anything with the group. And we will unmute you, or you can unmute yourself. But if anyone else would like to share, please consider yourself invited to do that now.
So this is Dean Gushy. I'm at Mason General. I spoke earlier about John. Again, I think I'm the only one who knows both of these guys. Matt was with me in residency. We were at UCSF Fresno. Matt was a couple years ahead of me, I think. And Matt was faculty for a while. I can't remember if it was a year or a couple years. But what I took away from Matt was, and listening to the story about Matt and how things went, that's very consistent with how I remember him. He was a guy who I have always tried to sort of mirror my practice after, because as a resident, what I observed was that Matt was always so incredibly calm and thoughtful, even when things were really ugly. Fresno was a very, very intense kind of place, knife and gun and level 1 trauma center. But I always noticed that when things got really ugly and patient was doing really poorly, what Matt would do would become extremely calm in the moment. And I don't remember if I took this from him specifically, but I remember I ascribed this to him, and I think he would say, just work the problem, and it was just a way to step back and calmly go after something very complicated. So, I really miss him very much in that respect. And John was similar in some respects as well. John was a super driven, very caring kind of doctor. And I took a lot from John as well, particularly his intense, detail-oriented kind of approach to medicine. I could never approach either of these guys' level of caring. I'm considerably more sarcastic than that, I think. But, both of these guys were incredibly caring physicians that I certainly have a piece of in my own practice. So.
Thank you so much for sharing it. It's amazing to me that there's a reason why I'm not an emergency physician. Well, I would never be able to stay calm amid what goes on in the emergency department. Anyone else want to share on behalf of these two men? Any memories or stories? You can raise your hand, I guess, or unmute yourself. We can then open it up to general sharing. I just wanted to sit on this slide a little longer since these are the men of the hour that we want to honor.
Well, I just want to add one more thing, Dean, that, you always say, quite honestly that, you don't like children. This is like the one thing you don't want to see is screaming, crying, snotty children. But John was exactly the opposite. And when we did the sharing sessions with the ER, and by the way, when this happened, thanks to Pamela Wible, we did kind of like therapy sessions, 4 of them over that 1 week. And it was emulated, I had thought of it initially because in the military, I was in the active duty military and I was overseas in Turkey. And we had some fairly traumatic things happen to us, deaths, and we would always stop everything at the end of whatever happened and just have a debrief, like in that moment. And whether it was an earthquake or whether it was a fatality in the emergency room, because I was the emergency room director at that time, believe it or not, at Incirlik Air Base in Turkey. And so it was incredibly helpful, because I remember we had the base reporter was 28 years old. He died of a massive pulmonary embolus. His brother had died of a massive pulmonary embolus at the age of 28 as well. a few years before that, and no one had was able to figure out what he was dying of. And I ran the code for about 45 minutes trying to save this beautiful young photographer, the base photographer. And it was so traumatic. And then everybody just disappeared at the end. You know, when we called the code, everybody just left. And one of the surgeons, we used to call him the Godfather, said, you know, everybody get together in my office now, you know, and he just sat around with like 10 of us and talked about what had just happened, talked about what had happened with his heart, how he died, and we all just shared, and it was such a release. And it's something really important, like you had said, you know, these feelings have to be felt. Like I kind of broke down earlier, I apologize, but I
Oh,
was
please don't apologize. I want to let
but
everyone know.
I was trying, you know, and Linda felt the same way, I think, and she was much stronger than me, and she was able to get through it. But you know, sometimes it just hits you, you know, because like you said, those stages of grief just go in cycles. But you have to really feel the feelings to get through this. And I think what happens is, like you say, you know, you put all the, we don't talk about it, if we don't share what our feelings are about it, and don't share with each other, I think we just become either hardened or less human. And this is not what John was. John was a very human person, and John was a very caring person. I've never seen a more caring person. You know, he'd give away all his iPhones. Every time he had a new iPhone, he'd give his other one away to somebody who would want to have it. He was a very generous person, and very intelligent, and I respected him greatly for his intelligence and his thoughtfulness. And he just seemed like the person you could reach out to and trust, you know. And I trusted him with my son to go on that, you know, on that job shadow. So yeah, he was a great person. I think honoring him is important.
So Kevin, just to be clear, you didn't finish the pediatric story there. I don't dislike children. It's just when John and I were on, we had an agreement. I preferred the people with big diapers, and he preferred the people with little diapers, and that was, so we had this this deal going forward.
Thank you, Dean.
Just to be clear, I'm not that heartless.
One other thing on John that really struck me during those sessions, the debriefing sessions at Mason General, is how many times he was vocal about being on antidepressants or having depression or anxiety, and the reaction of the other doctors who he would try to engage in a conversation. Anyone want to share what that was about?
Yeah, you know, and this is all in retrospect, because, you know, we all spend a lot of time in retrospect, but I do remember in a meeting, we were counseling another physician who was getting in trouble for something. Dean was in the meeting as well. And John spoke up, said, you know, hey, you know, it's okay. I'm on medication, and, you know, I have anxiety. I'm seeing a counselor. I think everybody should be on medication. I think it's great stuff, you know. And the response really was like, okay, thanks for sharing, you know. And I think that has triggered me to now say, if someone brings up something, Pamela, is like, go to the next level, you know, maybe not in that meeting, but afterwards, and say, hey, talk to me about what's going on, you know. And I didn't do that. And I don't think a lot of people did. And I think that's just a normal reaction. We're like, well, that. And I think what Pamela said was that maybe he was just trying to break the ice so that he could talk about it with someone. So that was that.
Because I think we do need each other. There's a way that maybe John needed to commiserate with other peers at Mason General and the emergency department and elsewhere who had the same occupational stresses, right? That I don't know who his therapist was, but, you know, presumably it wasn't an emergency physician. And I feel like there's specialty specific stressors that we really need to process within our specialty. So, so yeah, I think what I'll do is I'll stop the screen share, and then maybe we can see everyone. We can go to a gallery view or whatever, and I'm happy to answer any questions or to open the floor for others to answer anything that's brought up, if somebody wants to share. We can do this by, I guess, raising your hand or and sharing, or if there's generally some repeated themes in the chat, some questions that anyone would like to ask anonymously.
There aren't really any questions in the chat. A lot of a good back and forth, a lot of sharing, a lot of kudos, a lot of anger at the system, a lot of desire to make change, which that makes me very motivated. So yeah, that's what's in the chat. We're
Okay.
saving everything. So
Great. So what I did is I just posted in the chat some things that I prepared ahead of time that I think are really good resources for likely what's going on in people's minds about, well, where do we go from here? What to do next? There are 4 really good resources there, including a 24/7 while I'm awake access to me to have private conversations. And I, at this point, just want to share, because we have, if we're going to end on time, sorry, we went a little over there. If we're going to end on time in 10 minutes, I want everyone to realize that I do have this is being recorded, today's session right now, and hopefully this will be available for the people who missed the session that could really benefit from hearing this. And there will be a confidential session in my own Zoom room. We'll put a link up in the chat. For those of you who are just attending this, you might want to cut and paste out of the chat things that are of it, maybe cut and paste the whole chat if there's resources there. And there is the link just posted for the follow-up, probably a smaller group of people who want to continue to discuss this in a confidential format. So I am available with no cutoff, no time cutoff. You know, I kind of hate doing these suicide talks where everyone's like, well, it's 9 o'clock, it's over, good luck, have a great night, see you next time. You know, I think it's really important to leave a space for people who have various feelings that they would like to share and not have recorded afterwards. So anyone else that would like to ask a question or make a comment, because we do have family members here of these 2 gentlemen. If I